who is our professor and in charge of our pediatric rheumatology clinic, Government Medical College, KOZHIKODE. Okay, over to Manjusha.
Before that, I would like to invite Anandageshwan sir to say a few words.
Very good evening.
Just a
minute
silent.
Yeah, 1 minute. Okay, thank you. So, respected State Secretary Dr. Gobi Mohan, State Treasurer Dr. Binikutan, Program Coordinator Dr. Mohan Das Nair, all the darling Madam, Purushottam sir, all senior faculty members, and Dr. Kishore, student or colleague or friend and the I think he'll fits to all the category. He's my student, he's my friend, and a very great academician and a clinician. I think I congratulate Dr. Mohan Das to select Dr. Kishore for today's evening. Anyway, happy to see that our academic program is going very strongly and very actively. Every week we have different types of program. Previously we had clinical presentation only, but now we can see that a varieties of program. So I think we can expect similar more and more different program in future also. So I wish today's program all success. Thank you. And Kishore, very happy to see you again. Thank you.
Like to invite Dr. Gobi Mohan to say a few words. Secretary IAP Kerala.
Respected dignitaries and my dear friends, I would not like to take much time. Let's move on with the academics. Thank you very much.
Okay, thank you, Gopi. So we can start our academic program. I would like to welcome Dr. Kishore. As Anandageshwan sir mentioned, I still remember Kishore when we joined as assistant professor in Calicut. Kishore and team were very enthusiastic team of postgraduates. And after that, Kishore used to visit our department every year, and he used to help us in solving difficult cases in rheumatology. And Dr. Geetha also, who is dealing with the rheumatology clinic of IMCH and professor of pediatrics, also is there as faculty. Geetha, you are here now? Geetha? Geetha has joined. Okay, she may be. Geetha is there. Okay. Today's case, it is a difficult case, and that is one reason for inviting Kishore as the faculty. So we will start. Over to Kishore. Kishore?
Share screen sharing that.
Manjusha screen share.
Can you hear me?
Yes, yes.
Yeah, thank you very much. Yeah, I think I'll wait for Manjusha to share the slides and we'll discuss as we go along. Is that okay? I was thinking that I could summarize the whole case with a few slides and some discussion. Is that okay at the end?
Yes.
Thank you.
Apart from the clinical discussion, we expect to go through the investigations and also to few aspects to the management.
Sir, present. Shall I present, sir?
Yes.
Presenting the case of Shamil, 10-year-old male child.
Your name
hailing
here,
from.
Manjusha.
Yes, sir.
You can put your name.
It's Manjusha.
Manjusha.
Our JR3 from
MSR 30 something.
Presenting the case of Shamil, 10-year-old male child, hailing from Malappuram. Informant is mother. History is reliable.
Wednesday.
Presenting complaints. Pain in the right wrist joint for 10 days. Pain in the left hip for 4 days. And pain while chewing for the last 4 days. History of present illness. Child with musculoskeletal pain who is on chronic medications taken once daily on Saturdays for the last 4 years presented with complaints of pain in the right wrist for the last 10 days. The pain was of deep aching in nature, affecting his daily activities like eating and dressing, present throughout the day with no variation, and associated with swelling and warmth around the joint with no radiation. It was worsening with activity and improving with medications. He also gives history of night pain that disturbs his sleep. No history of any morning stiffness. 6 days later, along with the persisting wrist involvement, child developed pain in the left hip joint, presented as difficulty in walking, getting up from sitting position and climbing stairs. It was dull aching in nature that worsened with prolonged standing and sometimes radiating to the lower back and thigh. There was no associated obvious swelling or redness in the area. At the same time, he also gives history of difficulty in chewing with pain in front of bilateral ear with no radiation. It was also associated with redness and swelling in the left upper gum just above the first premolar. They consulted a nearby dental clinic. X-ray was taken, found to be abnormal, and was referred here for further management for all these symptoms. The pain medication was continued, and after 5 days, symptoms resolved, and child came back to his normal state of health. No history of any fever or rashes during the episode. No history of any loss of appetite or loss of weight. No history of recurrent oral ulcers or photosensitivity. No history of any skin rashes, pitting of nails, scalp lesions or hair loss. No history of any rash over upper eyelids or knuckles. No history suggestive of proximal muscle weakness. No history of any redness of eyes or decreased vision. No history of any abdominal pain, nausea, loose stools or blood in stools. No history of any chronic cough or contact with tuberculosis. No history suggestive of any small joint involvement. Past history. Child was having similar episodes for the last
Sorry,
4 years.
Manjusha,
Yes,
can I please stop you there?
Yes, sir.
So I think we're all taught as undergraduate students that we should probably have a list of differential diagnosis at the end of history of presenting complaints. So based on the story you have told us of pain in multiple sites, so mainly wrist, opposite hip, and the jaw, what would be your differential diagnosis at this stage? I'm aware that we have not discussed the past history at this stage, but it's always good to have draw up a list of differential diagnosis when you see a patient for the first time.
The child was having pain in the right wrist joint, left hip, and the TMJ. While chewing, he was having pain. And the 3 joints are mainly involved. So we can take it as oligoarticular JIA.
Okay.
And then.
So would you call it JIA yet?
Should be 6 weeks. At least 6 weeks duration should be there.
Yeah. So I
Can
think the
be
best
evolved in
thing
JIA.
would be I would say this is probably likely inflammatory arthropathy for which we need to find out the cause. So that will be the differential diagnosis at this stage. Obviously, I'm mindful that we have not gone through the past history. But given that story, I think you have given a very elaborate list of negative history. So shall we just go to that slide?
Yes.
For people who are attending, just to clarify. So you have mentioned there is no history of fever or rashes during the episode. So I presume you had systemic onset JIA in your mind?
Yes, sir. Yes.
There is no loss of appetite and loss of weight. So I presume you had malignancy in your mind? There is no history of recurrent oral ulcers, photosensitivity, which means you had lupus in
Yes,
your
sir.
mind.
Yes.
No skin rashes, pitting of nails, scalp lesions, hair loss. So you were thinking about psoriasis, which is very good. And it's very important to rule out psoriasis in these patients. I'll come to that a bit later. No rash over upper eyelids or knuckles, which I presume you are looking at dermatomyositis rash. And redness of eye, decreased vision. I presume you were worried about uveitis. And abdominal pain, nausea, loose blood, loose stools. You were worried about inflammatory bowel disease because there could be IBD arthritis. Chronic cough or contact with tuberculosis, you wanted to make sure this is infective. Although tuberculous arthritis usually presents in a more subacute manner, and it's more of a moroarthritis. There is a subtype of tuberculous arthritis, which can be like reactive arthritis, Ponson's disease, which usually affects symmetric large joints. So it can be bilateral in that situation. But the primary tuberculous disease is really, but again, that's a question you would definitely want to ask. And I presume you meant you were specifically referring to a rheumatoid kind of phenotype by asking for small joint disease. Is that right? Okay,
Yes.
thank you. You can go on.
Past history. Child was having similar episodes for the last 4 years, with child being normal in the intercurrent period. At 6 years of age, started as pain in the right hip, left knee and bilateral elbow, sudden onset, non-migratory, associated with restriction of movements. No swelling or fever was noticed during that time. And child was on close follow-up since then, diagnosed as a case of rheumatic disease and started on medication that was weekly once. And he was relatively well during the initial period. Yearly all-body MRI was taken. Mother reports that although child was not complaining of any pain, changes were noted on one of the routine MRI scan. And for the last 6 months, child is having recurrent episodes of joint pain, only affecting the large joints, minimum 1 episode per month, with symptoms controlled on analgesics. And child was advised admission, but was not willing due to personal reasons.
Okay. So I think I know we don't like to just give too much details, but based on that history, what is your presumption about what the diagnosis was and what the likely treatment child underwent?
So from this history, we can be polyarticular JAE or rheumatic disease involving for 4 years. For the last 4 years, child is having the treatment he's taking maybe methotrexate, usually given on weekly once. Usually given as weekly once. Saturdays.
My slight disagreement with that is I presume they did think about CRMO as well, because there is a story of whole body MRI, isn't it? Because
Yes.
normally you would not monitor a patient who is got a polyarticular disease. It's usually a clinical monitoring, isn't it? You don't end up doing a whole body MRI. One of the few indications in rheumatology where we go for whole body MRI is CRMO. So apart from JIA, my differential diagnosis would be CRMO, which was treated with methotrexate. Yeah, continue.
Needle history. Second child of non-consanguineous marriage. Antenatal scans were normal. Term vaginal delivery with a birth weight of 3 kg. Baby cried soon after birth. No NICU admission was required. Urine and meconium passed within 24 hours and breastfed within 30 minutes of birth. The child was discharged on day 3. Immunization history. Immunized up to age. BCG scar is present. Last taken vaccine at 10 years. No history of any adverse events following immunization. No optional vaccines were taken. Developmental history. The milestones were attained till age. No history of any developmental delay. It's having good scholastic performance. Diet history. Exclusively breastfed up to 6 months. Complementary feeding was initiated at 6 months. By 6 months, breastfed up to 1 year. Now on mixed diet, and he's having 110 kilocalories of calorie gap and 5 gram of protein gap. Family history. No history of any contact with TB. No history of any musculoskeletal pain, skin disease, bleeding disorder, eye disease, or malignancy in the family. Socioeconomic history. Mother studied up to +2. She's a housewife. Father, he was a driver, expired 6 months back in a road traffic accident. Now they live with the help of social support groups, live in a rented house with 2 rooms, 4 members in total, separate kitchen and latrine present. In modified Kuppuswamy scale, they belong to upper lower class.
Manjusha, if you just go back
sir.
to your last slide about the family history. So what are the things you would be worried about in this family history? I mean, or what are the things you would want to ask with the history of presenting complaint we just
Sir,
discussed?
in cases like psoriasis, in
Yeah, that's very
psoriatic
important. History of
arthritis,
psoriasis is very important. Yes.
psoriasis in a first degree relative is important. And
Yeah.
also enthesitis related arthritis can also
Yeah.
have
So basically,
can ask.
early onset arthritis. When people talk about arthritis in the family, 90% of the time they are talking about osteoarthritis. So we need to clarify whether this is inflammatory arthritis that we are asking about, and especially at a young age. So yeah, the two conditions which I would be worried about in history would be psoriasis and enthesitis-related arthritis. And sometimes and you rightly mentioned eye disease, because you can have eye uveitis preceding arthritis. So patient may have been picked up to have uveitis, and a timely treatment of uveitis can sometimes stop the arthritis from manifesting. So that's actually, again, a very relevant history. For completion's sake, I probably would have asked inflammatory bowel disease as well as a part of this. Yeah.
Can I intervene? Sure.
Yeah.
Manjusha, from this pedigree, I am getting an impression that all these members are affected by a
Affected, yes.
particular disease.
Color.
Okay.
Sir, I presume
Adam.
that it was not the coloring in, it was the arrow that was
I know.
significant. Yeah.
And there should be three-tiered family.
Yes, sir.
The only, I think, two. I can see only two.
Yeah, please continue.
Okay, sir. General examination. Child is alert, active, sitting comfortably in chair. The vitals: pulse rate 100 per minute, regular in rhythm, normal volume and character. No radial or radiofemoral delay. All peripheral pulsations were felt. Respiratory rate was 28. Febrile. Saturation was 98% in room air. Capillary filling time less than 2 seconds. BP was 98/68, normal to his age and length. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema was noticed. Anthropometry. Height for each. It was between -1 and -2 standard deviation. Weight for each between -1 and -2 standard deviation. BMI was 50, -1 standard deviation. Head circumference was normal. And head to foot examination. Head size and shape was normal. Hair, no alopecia was noted. Face, no dysmorphism. No redness or synecdoche was noticed in eyes. Ears and nose normal. Oral cavity, dental caries were present. The small white fluctuant swelling, 0.5 into 0.5 centimeter, with erythematous borders just above the first premolar was present. No oral ulcers were noticed. Trunk and spine, no visible chest wall deformities, no kyphosis, scoliosis, or gibbous. Limbs, mild fullness in the right wrist joint present in the dorsal aspect, with no redness and no limb length discrepancy.
So was this
No
swelling tender, the one in the oral swelling?
It was tender, sir.
So what do you think it is? It's like a mucus cyst, or is it epulis, or do you get a feeling of what this could be? So it's not a bony swelling, it's a fluctuant swelling, you say?
Yes, sir. Not bony swelling.
And you mentioned about trunk and spine.
Yes, sir.
Suppose spine is very important. That's absolutely good that you mentioned that. And it's also important. Why did you talk about chest wall deformities?
In conditions like CNO, the ribs
Yeah.
will be affected.
You can get rib involvement,
Rib.
and equally, most importantly, you can get significant sternal involvement, especially if it's the Sappho subtype. The Sappho syndrome is like more of an adolescent/adult equivalent of CNO, where you can get significant chest wall, especially anterior chest wall and sternal involvement.
No hirsutism, striae, or cataract. No rash, skin or subcutaneous nodules or nail pitting was noticed. No deformities anywhere in the body. No tendinitis. Achilles tendon was normal. No acne or pustules. Genitals were normal. No neurocutaneous markers. No stigmata of vitamin or micronutrient deficiency.
Again, the two things very important here is what rashes would you look for in a patient with this history?
You can look for evanescent rash, which is present in Sogia.
Yeah.
And in case,
But the clinical picture is not like
yes, sir.
psoriasis, isn't it? I was particularly relevant to this patient.
In psoriasis, we'll get
Yeah, psoriasis is very important. And what
silver
kind of psoriasis do you get? Yeah, you get there is a higher incidence of palmar-plantar pustulosis in these patients. So psoriasis, the typical classical psoriasis, palmar-plantar pustulosis, and that's something you would be worried about in these patients. So those are the two rashes I would be particularly concerned about. Yeah, you can continue.
PGAS, and PGAS screening
Sorry, can we
questions.
just go back to one more thing? You mentioned about vitamin deficiency.
Yes.
Can any vitamin deficiency present with this picture?
Vitamin D deficiency can present as musculoskeletal pain.
Yes.
Scurvy. Vitamin C deficiency can present as pseudo.
Have you seen a patient with scurvy?
Yes, but not
Yeah,
with
so
classical findings.
it is becoming coming back. So scurvy used to be a disease of the sailors, which effectively went off the medical practice for the last few years. But in the last 5 or 6 years, we have seen a return of scurvy, mainly in children who have got significant autism spectrum disorder, who have extremely limited diet. So there was a patient who presented with generalized musculoskeletal pain with significant widespread bony changes, who is significantly autistic, non-verbal, and his only diet was chocolate cookies for the last 3 or 4 years. So I think with the food fads associated with autism spectrum disorder and the neurodiversities that we see, I think we need to think about scurvy. It's slowly coming back into clinical practice. I don't know how common it is in India, but maybe parents can still control about feeding their children, whereas here sometimes we do see patients whose diets are extremely limited. There was another child who was just having milk and milk products, nothing else at all. So with food fads associated with neurodiversity, sometimes we need to think about scurvy. So diet and stigmatovitamin deficiency is significant with this presentation. Yeah, keep going. Sorry.
So can you say a little bit louder?
Yes, sir. Yes. PGAS screening questions. Child had pain and there were problem with dressing and walking, and gait appearance was abnormal. Movement was also abnormal. Arms appearance and movement abnormal. Legs also abnormal. Spine was normal. Appearance of hand and wrist. Left wrist swelling was present with no redness, no wasting, no deformities. Tenderness over the wrist joint was present. No tenderness on squeezing the metacarpophalangeal joints. The extension and flexion of wrist joint was limited. Movements of proximal interphalangeal, distal interphalangeal, and metacarpophalangeal joints were normal. Still was able to make a normal fist, able to tuck fingers into the palm. And hip joint, there was no wasting, but child had a limping gait with tenderness present over the left sacroiliac joint and bone tenderness over the iliac part of iliac bone near to sacrum. And the extension and flexion movements were painful. Abduction and adduction were restricted, and internal and external rotation was also abnormal. Temporomandibular joint, there was no swelling. Tenderness was present over bilateral temporomandibular joint and also on bilateral mandible close to the joint. And there was restriction on opening of mouth.
So can you summarize your musculoskeletal findings?
Yes. So child was having difficulty. Child was having pain along with problems in dressing and walking. All the screening questions were positive. And also child had an abnormal gait with abnormal gait, and there was also mild swelling in the wrist joint with tenderness, with extension and flexion of the wrist was limited. In the hip joint, there was no obvious swelling, but there was tenderness present over the right sacroiliac joint and also on the iliac bone near to sacrum. All the hip movements were painful. And temporomandibular joint, there was tenderness over bilateral temporomandibular joint along with restriction in opening mouth.
You can continue. Yeah.
Yes. All the other systems were within normal limits. In summary,
Yeah,
10-year-old
continue.
boy, second born
Yeah.
to non-consanguineous parents, with history of multiple joint pain, predominantly lower limb joints, on and off for the last 4 years, on once weekly medication, with no history of any morning stiffness, occasional night pain present, with no relevant past or family history, and no history suggestive of SLE, inflammatory bowel disease, juvenile dermatomyositis, or psoriatic arthritis. On examination, there was mild swelling, tenderness, and restriction of movements of wrist and hip joint, difficulty in opening mouth, and tenderness of bilateral temporomandibular joint along with the adjacent mandible.
Yeah, you can go with the
So the
differential diagnosis.
differential diagnosis can be polyarticular JIA, enthesitis-related arthritis, or chronic non-bacterial osteitis. So
Okay. So what are
long
the
history
points
for
in favor of polyarticular JIA?
polyarticular JIA, the child had more than 4 joint involvement for over a long duration of time. For the last 4 years, child is having. Yes, yes, sir.
1 minute. I was late to join. I was here listening to in the history and the examination part. In the history,
Yes,
total duration of the illness is almost 4 years.
yes, sir.
A boy child having a problem, definitely Kishore analyzed the problem. Joint involvement, upper limb, lower limb, hip, wrist, and temporomandibular. A bit unusual for our experience for the bilateral temporomandibular in the pediatric age group, this entity. And very unusual about the gum part. So that was a little bit in the discussion, a bit unusual thing among the common conditions we are considering. So we are very interested to know about more about that part. So you needn't go in depth about that part of the gum problem. Then any condition with a joint problem of the lower limb, 4 years duration and the wrist, you should be including the functional disabilities of the child, because the social, emotional, and the functional part of a child definitely will be more important. So in the day-to-day activities, what all ways that is affecting the child's activities, because there can be adolescent, he's going into adolescent ego, peer relations and the school attendance, and all those things are important, especially when the hands are involved. I was listening when you are talking about the movement of the fingers, he can make a fist. Okay, but the wrist movement is abnormal. So day-to-day activities of using the hands are very important, about the feeding, about the writing, drawing, whatever. So whether those things are affecting his daily activities is very important. And about the walking, definitely the sports activities or some other things in the school which the patient may feel problematic, but it's inevitable. But what about the other activities like he can do daily movement, going down the steps, which ground level or upper level, because the society should be giving considering all these things. So whether he's getting all the benefits from that, okay, then going into what sort of an ambulation or auto, whether he's able to going to get into the taxi vehicle like that. That part you didn't mention in the history, because pediatricians with the social thing will be more important. Of course, it is a discussion of the main difficult case of the joint problem. Anyway, in the general examination, you mentioned about the growth in height and the set score. Okay, set scoring, that is not enough, because always the chart with the mid-parallel height and the potential, those things are important. Because a long duration problem involving the joints and the potential should be always compared with the mid-parallel height. And those chart definitely should be there. And in the general examination, when there is a limping, should there be a measurement of the segmental length? There can be an asymmetry. That assessment also is important. Okay, those things. And in the examination, by the time you finish, all systems are normal. You just moved on without telling. Because in a condition like this, you need to give importance to, already you have mentioned about the visual problems, eye congestion, visual problems and what. You need to examine the eye with your torch. It may not be an ophthalmologist. What about the pupil's shape? And those,
No sign was found, sir.
okay. Clinical examination is very, very important, including head to down and the scalp. You need to palpate because there is an unusual gum swelling. So there can be, you need to tell about the bone defects or something. And the eye examination, cardiovascular system definitely need to be mentioned. Even though all systems are normal, we can't move like that. Pulse rate is 100, a bit unusual for a 10-year-old child. Did you repeat it? So otherwise, it's a little tachycardia. There's nothing to explain for that. So all those things, you need to tell the relevant system examination. Okay,
Okay.
good. Okay, sir, go ahead.
Thank you very much, sir. I was going to ask about the impact of this on the child. That is how we generally sum up musculoskeletal. It's very important from a 10-year-old who is a very keen footballer not to be able to play football because it's more important for him than taking the medicines, I think. So things like that, it will be good to sum up with the question we generally use is all children here in school do PT sessions. We call it physical education sessions twice a week. So that is usually a basic benchmark for us to see whether how are they coping with activities. Is or are these problems impacting their life in any way? And the second question we ask is most of the children here have some kind of activities outside of school, like dancing or sports or swimming or something like that. Again, are these joint problems or are these musculoskeletal problems affecting them? Is the question we need to ask a little bit. So it is very apt that sir mentioned about the impact of the symptoms on the life, because at the end of the day, as pediatricians, if the X-ray improves, we cannot be happy just because the X-ray improves. We need to be happy only if the child improves. So I think we need to treat the child in front of us than the laboratory investigations or the radiology images. Am I audible now?
Yes.
Yes, yes.
So in terms of polyarticular JA, you mentioned that cumulatively the patient has definitely had 5 or more joints. Secondly, enthesitis-related arthritis. Why did you use that as one of the differentials?
Child was having sacroiliac joint pain.
Yeah.
That was a feature of, that's a feature of enthesitis-related arthritis.
Yeah, and
It's
if you
boy
look at
child, boy.
the classification of JIA, ILAR classification of JIA,
Yes.
any boy child, any boy over 6 with a oligoarthritis picture, one should suspect enthesitis-related arthritis. So that's a good point. And thirdly, CRMO, I presume, as we discussed, because there was a history
Yes.
of whole body MRI, and the symptoms are not all typically joint related. My question would be then, how do you explain the episodic nature? What does that suggest? So which of these is more likely with that episodic picture?
CNO can present in episodes, sir.
Yeah, so it's very well known to be episodic with relapses and remissions. If the patient with polyarticular JIA is poorly controlled on methotrexate, I would expect the symptoms to flare and remain there without up and down. Because in both the other conditions, enthesitis-related arthritis and polyarticular JIA, unless we give some systemic steroids or we escalate the treatment by adding in another agent, the symptoms are likely to persist. Whereas in CRMO, just with NSAIDs, the symptoms can get better, but then relapse once you reduce the dose of NSAID. So that recurrence pattern points a finger more to chronic non-bacterial osteitis. So one point I really wanted, I forgot to mention this earlier when we discussed past history, is in these patients who expect periodicity, it's always very important to ask whether they have been given any systemic steroids at this stage. And that is important from this patient has had it for 4 years, so it's less likely. But if somebody has come to you for the first time with musculoskeletal symptoms and you've given steroids, that it's very important because you could be masking malignancy there, number one, which is unlikely in this child. And number two, the systemic steroids would be actually causing the periodicity than the true periodicity of the pathology itself. So the patient would get symptoms for 2 weeks, they would give 3 doses of prednisolone and it would go down and come back in 2 months. So it's very important to make sure that the periodicity is not because of intermittent steroid or other treatment. So I presume there is no history of steroid intake, but sometimes we have to be very specific as to, especially practitioners may give, you can have this for 3 days, symptoms would get better. So we need to really clarify and make sure that there has been no use of systemic steroids until now. Yeah, you can continue. Thank you.
Yes, sir. On to investigations. Child had an ESR of 120, CRP was 20, total count was 8,600, neutrophil 70% and lymphocyte 25%, HB was 10.2, the platelet count of 3.3 lakh, ANA done was negative, HLA-B27 PCR was done, was also negative, R of Vector was less than 10, negative.
So based on these investigations, which of the diagnoses look more likely now?
The enthesitis-related arthritis can be ruled out. Say HLA-B27 PCI is negative here. And also polyarticular JIA, the R factor is negative, can be there. Most probably points to CNO, chronic non-infectious.
So I think HLA-B27, not all enthesitis-related arthritis have to be HLA-B27 positive. Depending on what study you look, it's between like 30 to 70%. So just because HLA-B27 is negative, you cannot say it's not enthesitis-related arthritis. And you can get raised inflammatory markers in that. In terms of polyarticular JA, there are two subtypes. There is rheumatoid factor positive and negative. So rheumatoid factor negative polyar JA is in fact more common. So we could not say for certain. If it's rheumatoid, you would classically get small joint involvement, symmetric small joint involvement, especially of upper limbs and to some extent lower limbs. So it looks more like an RF negative poly if it is a polyarticular JIA. And I really don't know what the Indian cohort of patients usually show. It's very rare that we get a CRMO patient with an ESR of 120. They can get like 20 to 30, maximum 50. It's not very sky high in patients with CRMO. And sometimes when we get patients with CRMO with very high inflammatory markers, especially if they are coming for the first time, we actually investigate them a bit more, like probably biopsy and other things to make sure we are not missing an infection or a malignancy. Infection is much less of a problem if it's a multifocal osteomyelitis, which is very rare in an immunocompetent child. But we need to think highly about malignancies if the ESR and CRP, especially the ESR comes back as more than 100, I'll be slightly uncomfortable to presume that it's because of CRMO.
Kishore, one doubt regarding clinical. When you're presenting the right and left wrist, there is a limitation of movements and already deformity is setting. So how common is the deformity of a joint in CRMO? Usually the CRMO will be involving the long bones more than the joints. So in that situation, deformity of joints, does that argue more for CRMO or against?
So CRMO, no, it doesn't argue against, sir, because CRMO, one of the commonest complications of CRMO is hyperostosis, which then leads to deformities, especially in patients who have got clavicular and mandibular disease. So it is not unusual for patients to have deformity because of CRMO. And the commonest causes for that was they often get a reactive hyperostosis, depending on how long, because the longer they are untreated, the higher the risk of hyperostosis, and that can lead to bony deformity. So I would not say that is not in favor of CRMO.
Right. Malignancy you can almost rule out because of the long 4
duration. Yeah. Without any steroids, definitely.
Manjusha, one point, whenever you are discussing a chronic illness, we need to consider the basic illness, how it is moving forward, it's controlled or progressing, and all sorts of complications. At the same time, what you forgot was you was on long duration medicine, methotrexate weekly for the last 4 years. So need to consider the problem which are very likely to be associated, caused by methotrexate. So in that situation itself, the system which are likely to be involved, one is the liver. You forgot when you are talking about the system examination, all systems normal. It should not be, we should not go beyond without mentioning the lung and the liver. And in the examination, the investigation, liver function test and ultrasonogram should be done to assess the liver. Long duration methotrexate. Okay.
One more suggestion. Is it worthwhile in the history and in the examination in trying to differentiate whether the symptoms are confined to the joints or any other than joints are also involved? So was that effort properly taken? I am doubtful.
So one of the questions we ask when we assess musculoskeletal symptom is, children can report joint pain not just from joint pathology, but even pathology adjacent to the joint. So if there is a problem with distal femur, it gets reported as knee pain. If there is a problem with distal tibia, it gets automatically reported as ankle pain. So sometimes there is definitely, if there are no signs of inflammation like swelling and warmth, it is always better to the easiest thing to do is when you examine the child, you can show, does it hurt here or does it hurt here? Is it actually in the joint or is it close to the joint? Because in children especially, they are very poor at localizing to everything close to the joint gets interpreted as a joint pain. So it's during the examination is the best time to try and decipher out whether the problem is actually within the joint or just next to the joint. Again, that may not be 100% reliable anyway, but that's a good practice to do. I agree with Monda, sir, completely. Yeah, you can move on. Thank you.
It was the X-ray showing
Yeah.
sacroiliac joint deformity and
Yeah.
joint erosions are seen.
So I'm very surprised. This should be the first X-ray, isn't it? One of the first
Yes, sir.
X-rays. So
Yes.
it is very difficult to kind of explain an erosive change in the very first X-ray. So he may have had this for a long time, even before 4 years is my guess, because for you to have erosion of a joint, especially sacroiliac erosion, it needs to have gone on for at least 6 months. So I presume, although he presented in November or October 2021, he may have had symptoms on and off for a few months before that, is my guess. You can continue. Yeah.
Yes. The MRI was taken. Initial MRI showed patchy marrow edema seen in the right posterior iliac bone, right posterior acetabulum, right sacrum adjacent to the sacroiliac joint, and the left femur subtrochanteric region, was CRMO most likely.
Yeah.
And next year, the MRI showed moderate bone marrow edema involving the sacrum and iliac bones on the right side, with minimal joint surface erosion involving the right sacroiliac joint, predominantly on the sacral side, likely osteomyelitis. Minimal marrow edema involving the sacral side of left sacroiliac joint, bilateral greater trochanterus, and proximal femoral metaphysis.
So based on these two scans, Manjusha,
Yes,
how
sir.
can we narrow our differential diagnosis further?
So marrow edema is usually seen in chronic non-bacterial osteitis.
Yes.
It's a usually typical feature of, and also there is bone involvement other than the joint involvement.
Yeah. So I think sometimes it becomes difficult to differentiate sacroiliitis from sacral edema in patients with, or sacral and iliac edema in patients with CRMO. So it is actually a big debate. A lot of articles and textbooks have been written about, or not textbook, chapters have been written about how to differentiate CRMO from enthesitis related arthritis. I'll come to that discussion a bit later. But generally, when you get more involvement of the sacral bone, the sacral ala, and the sacral wings and iliac bone without SI joint involvement, you think it's more likely to be CRMO. And even if there is sacroiliac joint involvement, if it's unilateral, it again is less likely to suggest an enthesitis-related arthritis, because you would expect usually a bilaterally symmetrical sacroiliac involvement, although it is not always the case. So when you get a significant unilateral involvement, only one side with extension into acetabulum and sacral iliac crest and greater trochanter and everything, that makes you suspect that this is probably more of a CRMO than an enthesitis-related arthritis. However, all the points we mentioned, like greater trochanter, they are also enthesis pressure points. So you can get enthesitis, can involve patchy involvement in some of the sites, can also be because of enthesitis. If that is the case, that makes you suspect whether this is an enthesitis-related arthritis. So these are the 2 points by which you make this differentiation. I'll come to that a bit later as we go along. So I don't want to interrupt the presentation. Keep going.
Whole body MRI scan showed hyperintensities involving sacrum, posterior iliac bone bilaterally, with diaphysis of right femur and tibia and talus. In this admission, MRI was taken and it showed mild bone marrow edema involving sacrum and ilium on the left side, with minimal joint surface erosions and mild effusion in the right sacroiliac joint with joint surface irregularities, in keeping with bilateral asymmetrical sacroiliitis, mild marrow edema of bilateral ischium and left greater trochanter, and features suggestive of osteoarthritis involving bilateral temporomandibular joint, more on left, with osteonecrosis of left mandibular condyle and degenerative changes involving the articular disc.
Okay. So that is a very interesting point that you mentioned there, because temporomandibular joint involvement is fairly common in patients with JIA. So a lot of our patients with JIA have, and there were some studies say that if you were to do an MRI scan in all patients who presents with JIA for the first time, there are studies which say that up to 30% of them, even up to 50%, may have asymptomatic TMJ involvement. So temporomandibular joint, and that is always when you get temporomandibular joint inflammation, because it's such a crucial joint, we tend to use that to escalate treatment by adding in new treatments or try joint injections and stuff like. So TMJ involvement is quite typical of GIA. However, patients with CRMO also are well known to have mandibular disease, but the mandibular disease usually happens in the ankle of the mandible rather than in the articular area. So given that this patient has got damage to temporomandibular joint, again, that kind of points more towards a JIA having caused an untreated JIA having caused an erosive damage leading to osteoarthritis of the mandible, of the TMJ. So again, here it looks more like a joint involvement rather than a bony involvement, which is what we typically see in CRMO. So essentially, I'm coming to the point that this patient probably has got mixed features, and I'll come to that later. Please continue.
Bone scan was done, showed increased osteoblastic activity in right ilium adjacent to the sacroiliac joint, corysacroiliitis, and focal increased osteoblastic activity noted in the left greater trochanter. It was done 4 years back. Bone marrow was done with cellularity normal, with normal erythroid and myeloid series, with adequate megakaryocytes.
Is that the last slide?
Yes,
Okay.
sir, that's
So fine. Do you want to summarize just the relevant findings on clinical history, examination, and investigations, and then tell me, given that we have gone through all the imaging, what do you think is more likely now?
So the child is now he's 10-year-old male child with a history of multiple joint pains for the last 4 years. In the intercurrent period, he's normal, and predominantly he's having large joints in the lower limb. He's on weekly medication, and no history does not suggestive of any other arthritis. On examination, he's having mild swelling in the wrist joint with restriction of movements in the wrist joint, hip, and the temporomandibular joint. The investigations suggestive of the HLA B27 PCR, ANA profile, and R factor is negative, along with mildly elevated inflammatory markers. And the X-ray was showing joint sacroiliac joint erosions with MRI showing bone marrow edema, along with unilateral sacroiliac joint changes involving the long bones also. So most probably can be chronic non-bacterial osteitis.
Okay. So from a practical point of view, what would you like to do now?
Kishore,
child-
before we go into the discussion, after I saw the images and all,
Yeah.
I was reminded of this thing. You showed the hip involvement. So I'm interested about the daily activities going back. Which closet he was using, toilet? Was he able to use the European toilet? Country toilet is unthinkable. Was there any difficulty in using the European toilet? What about how much of the movements of the hip was possible, which are very important for a day-to-day activity, is the closet. Okay, whether he was able to use the closet is one thing. And the next thing, whenever the long duration hip or knee problems occur, you need to measure not only the length, there can be wasting of the muscles also. So disuse of the muscles, both are ways you need to do the measurement, length and the circumference, bulk of the muscles. Muscle involvement is another condition, but this can be secondarily involved. That measurement is important. At the same time, one more thing, when there is a temporomandibular joint involvement that should bilaterally for a long duration, a growing child. So what about the mandible? What about the
no micrognathia vespis.
Gnathia like that? And we should have a photograph serially and the bite of the teeth. So Kishore, how will you be monitoring all these kids over time? Will you be having a file of this data, documentation of the facies, photos and all you will be keeping?
Yeah, so sir, here TMJ assessment includes mouth opening is fairly crude. Generally, as a rule, we say that we should get 3 fingers in. If you can't get 3 fingers in like that, it's mentioned in PGAS, there is some restriction. Ideally, so what we do is we often, if there is a concern about chronic issue with the TMJ, we refer to our maxillofacial colleagues who actually do a proper measurement and advise our maxillofacial physios do advise about these joint injections. We have a very low threshold to do an MRI scan to look for early erosive changes. And if this was, and then when you assess these patients, the 3 things that helps you differentiate a TMJ disease from a mechanical problem. One is tenderness of the joint. And in the history-wise, they often have early morning stiffness, and they say they struggle to brush their teeth even, because the symptoms are that brushing is a very useful question to ask, because that's one of the things you need to open your mouth quite a bit to do first thing in the morning. So early morning stiffness, if there is early morning stiffness, the first question I ask is whether they struggle to brush their teeth. The second question, obviously, in terms of diet, do they struggle to do the 2 things you can ask? If you are very healthy, you can ask whether they can eat an apple. If you're not very healthy, you can ask whether they eat a burger. These are the 2 questions you can ask, whether you can open your mouth wide enough for that. And when you examine these patients, it's always better to look for mouth opening. Second thing is tenderness. And you don't really realize how quickly you can get asymmetry in these joints. That is very important. If you've got unilateral TMJ involvement, you can actually see a deviation to that side fairly early on. It only takes a few weeks to develop. So if we have any of these features, we try and organize urgent MRI, but if we cannot organize that, we just go ahead and treat them. So we give them steroids. Steroid injections are tricky in this joint because of a high risk of injury to facial nerve and other important neurovascular bundle that go through close to the TMJ joint. So we sometimes our maxillofacial surgeons do what we call a washout of the joint, the arthrocentesis they do. The second thing is it is usually an indication to escalate treatment. If the patient is only on methotrexate, we always add in a biologic. If the patient is already on a biologic, we may have to switch the biologic to something else. So we view the TMJ symptoms quite seriously. And sir, if there is already a deformity, and like you said, we do take annual photographs to see. And I have had 4 or 5 patients in the last 12, 13 years, no, maybe 3 or 4 patients who had to have a jaw replacement at the age of 18. So they do not do TMJ replacement until the growth is complete. So they wait for that. And at least 2 patients have had, and another couple of patients are waiting to do that. So jaw is one of the joints which are actually quite underplayed if you look at JIA, but it's very significant because the practical implications, the high risk of early damage, and the need to escalate treatment.
Kishore, she mentioned in the PGALs about the neck movements, flexion, yes, no movements and all. Should we routinely look for the CNS examination angle, jerk and all? Is it a common thing in the
No,
routine?
very uncommon. I have not yet seen a patient with TMJ who has got atlantoaxial myelopathy. It's extremely, however, if the patient has got neck pain, it is always good to do a flexion action view of the X-ray to look for whether there is early subluxation. But AAS as a complication of JIA is fairly rare. I probably had 2 patients, but we tend to do the open mouth view to look for any evidence of subluxation. And if there is any concern, we'll speak straight to the spinal surgeons.
Okay.
So Manjusha, do you want to
One
unshare your
question,
slides?
Kishore.
And
Sure. One question. This
Yeah.
oral
Hello, madam.
cavity, there is oral cavity, there is a fluctuant swelling. Is it related to the temporomandibular joint? It's
I
very
don't
near
know.
So, madam, actually, it was a periapical abscess, dental abscess. It was a dental
Yes.
abscess, not related to the
No, is it due to
temporomandibular joint.
osteitis? Osteitis, you can have that, no?
It is very
Abscess formation.
rarely. We don't usually get a soft tissue swelling when you get TMJ involvement or that. That was why I was very uncomfortable to presume that was because of this. If it's an abscess, obviously it is unrelated to this. But then he had restricted mouth opening, which is what worries me more than the abscess itself. So are you happy to stop sharing, Manjusha, so that I can
Yes,
share
sir.
my
Yes.
slides?
Okay,
That's okay.
Miss Adira, please make Kishore a co-host. Adira?
Yeah, I can share it now. Thank you. Can you see the slides?
Not yet.
Yes,
Right.
yes.
Is it moving? Yeah.
Yes, yes.
So in summary, this is a 10-year-old boy who has had a 10-day history of pain affecting the right wrist associated with swelling and warmth, left hip, and pain on chewing, with no systemic symptoms or red flags to suggest alternate pathology. However, he has had recurrent similar episodes for the last 4 years. And Manjusha mentions at least one episode per month affecting predominantly large joints, although I was not sure how long each episode lasted. Manjusha, do you remember? You mentioned
Yes, sir.
about, yeah. How long did they last, these episodes?
Weeks only, sir. For 1 week after taking naproxen, pain used
Yeah.
to subside.
Okay, that's again a big clue that this is a CRMO pattern, because you would not expect a JI or enthesitis related arthritis to completely settle down with naproxen. It makes CRMO more likely. And the patient was on weekly medication, methotrexate, and poorly controlled of late with no significant family history. Examination, apart from, there was a white fluctuant swelling, which we now know is epulis in the jaw, but then patient had significant restricted movements of the hips and the TMJ with tenderness and swelling and restriction of the left wrist. There was also tenderness over sacroiliac joint and sacrum. with raised inflammatory markers, especially ESR of 120, with normal full blood count, negative autoantibody screen, and negative HLA-B27. There is a documented bone marrow aspirate which did not pick up any hematological malignancy 4 years back. So in terms of imaging, initially it showed right-sided pelvic inflammatory changes, mainly bone marrow edema, which is quite typical of inflammation of the bone. And in March, then it extended to both sides and it showed possible erosion of right sacroiliac joint. Again, in whole body MRI showed almost confirmed CRMO by showing changes in femur, tibia, and talus. And the most recent MRI showed bilateral asymmetrical sacroiliitis and changes of rest of pelvic bone. Of note, the patient also has osteonecrosis of the left mandibular condyle, leading to osteoarthritis or chronic degenerative change of her left TMJ. The bone scans probably does not give us any more information. So the question is, I think it's very straightforward. Is the diagnosis CRMO, or is it enthesitis-related arthritis, or is it a combination? The other differential diagnosis, because of the sheer duration, are fairly academic. However, if this patient was coming to us for the first time or within 3 months of diagnosis, we would want to consider infection. A multifocal bone involvement would make infection much less likely. You would not expect a multifocal osteomyelitis in an immunocompetent child, which is why history of recurrent infections would be helpful in these patients. Is this a reactive picture because it's up and down? Is this a reaction to an infection? Again, highly unlikely given the duration and recurrence. We always need to consider neoplasia as differential diagnosis with bone pathology, but highly unlikely in this patient given the 4 years duration, presuming the patient did not have any steroids. There are no red flags in history and normal full blood count. It's always important to ask for the history of steroids because sometimes they can mask malignancy for much longer than we think they can. Again, very unlikely, but we just need to consider if it's an isolated bone pathology of inherited conditions, which are again unlikely. Is this a recurrent autoinflammatory syndrome? Highly unlikely because the patient doesn't give a history of fever or skin rashes to suggest that. And it does not particularly fit to any phenotype of periodic fever syndromes. Could this be something totally different like a skeletal dysplasia? Again, highly unlikely given that the involvement is very patchy. You would expect the bone dysplastic changes to be fairly symmetrical in most of the skeletal dysplasias, and raised inflammatory markers again makes the skeletal dysplasias highly unlikely. Now, coming to the crux of the question, is this CRMO or is this enthesitis-related arthritis? In this patient, I think we get a mixed picture. There are features that suggest both. For example, this patient had signs of inflammation in the wrist, which makes enthesitis-related JIA more likely. However, CRMO is well known to be associated with arthritis, but it's not a part of CRMO itself. Again, raised inflammatory markers, especially in ESR more than 100, would make me think more in terms of JIA, as the inflammatory markers are not that high in patients with CRMO. We often see inflammatory CRP and like 25, 30, maximum 50 in these patients. Again, asymmetric sacroiliac involvement actually makes CRMO more likely. We usually get bilaterally symmetric sacroiliitis in patients with enthesitis-related arthritis. However, TMJ involvement again makes enthesitis-related arthritis more likely because we would have expected a mandibular lesion, which is restricted to bone in patients with CRMO. Again, erosions. Erosions are very, very atypical of CRMO. You can get hyperostosis leading to deformities, but when you get erosive bone joint changes, especially affecting the sacroiliac joint and TMJ, an inflammatory arthropathy like enthesitis-related arthritis is more important. That takes us to one quick study which has been published in the past. What are the features, both clinical and radiological, that might help one differentiate between a spondyloarthropathy against CRMO? So I'm just going about the things that are relevant here. In 86% of the patients, there will be evidence of enthesitis. So when we look at the pelvic changes, if the pelvic changes correspond to the enthesitis points, that may actually more suggest enthesitis-related arthritis than CRMO in these patients. Again, presence of peripheral arthritis. This patient clearly had a swollen wrist, which makes it more likely to be enthesitis-related arthritis. But again, the imaging, what do we normally see in patients with enthesitis-related arthritis? We get enthesitis with arthritis and synovitis, whereas in CRMO, we classically get bone marrow edema, hyperostosis, lytic lesions, and sclerotic lesions. Given that the radiology, especially at the onset, is clearly more suggestive of CRMO. SI joint involvement is very important. In patients with spondyloarthropathy, enthesitis-related arthritis, we tend to get a symmetrical bilateral sacroiliitis. Whereas in patients with CRMO, it tends to be in the bones adjacent to the SIJ, especially the triradiate cartilage, pubic ramus, acetabulum, sacral ala, etc. So that is more suggestive of CRMO. So I think in this patient, we have got two features suggestive of CRMO and two features suggestive of enthesitis-related arthritis. I think the patient possibly has both. It started off as CRMO, given the periodicity, given the response to naproxen, and given the predominant involvement of bone, which is slowly evolving into enthesitis-related arthritis, JIA, given the TMJ involvement and the sacroiliac involvement. But the question then, from a practical point of view, from a treatment of point of view, does it really matter what we call it? The correct answer is there are some differences in these conditions. It's probably important. Why? One, in terms of treatment. If this patient had enthesitis-related JIA, the principle is always early aggressive treatment, early use of biologic, early use of anti-TNF to prevent erosive disease. The second question is, what about the choice of the agent? Again, in CRMO, we would in enthesitis-related arthritis, we would need anti-TNF therapy quite early to prevent damage. It is also important that certain treatments we use in CRMO, like bisphosphonates, will not work in patients for enthesitis-related arthritis. So given that the patient has got a mixed picture, we have to choose an agent that would work for both. And the consensus agent would be an anti-TNF agent like adalimumab or infliximab. Would we choose etanercept in these patients? In my mind, I would be very reluctant to do that because etanercept is well known to predispose patients to uveitis. Even though the patient is HLA-B27 negative, patients with enthesitis-related arthritis have a high risk of uveitis. So given that, I'll be slightly skeptical if I were to choose etanercept as the first agent. My choices would be use adalimumab or infliximab. And again, to find out the differential diagnosis is important also from a prognosis point of view. CRMO in children usually burn out. It's a condition which spontaneously is resolved over the years, whereas enthesitis-related arthritis is likely to be a lifelong condition, although they can have exacerbations and remission. So from a prognosis point of view, CRMO is better and enthesitis-related arthritis is probably less better. And we also need to think about the complications. There is a higher risk of erosive disease in enthesitis-related JIA, and whereas fractures and hyperostosis are higher in patients with CRMO. And we also need to monitor these patients for other complications like uveitis. So we would not normally send a CRMO patient to ophthalmologist to look for uveitis, whereas we may send a JIA patient, displaced enthesitis-related arthritis patient, to make sure there is no subclinical uveitis or visual impairment that has already happened because of a subclinical uveitis. Is there any questions? I'm happy to take questions. So Manjusha, what is the patient is on in terms of treatment at the moment?
So we have started on bisphosphonates. We started the child on pamidronate, IV pamidronate.
Okay. So is there a plan to start anti-TNF?
So we're planning to follow up the child.
Yeah.
Look for any symptomatic improvement.
Yeah.
Is she on a
I think the problem with using bisphosphonates is it would treat CRMO well, but it will not treat endocytes-related arthritis, and it may not prevent erosive disease. So I'll be very worried. I think because there is an element of CRMO, bisphosphonates will help in the interim, but I would have a very low threshold to start this patient if they can afford on an anti-TNF like adalimumab, because that is going to work for CRMO and enthesitis-related arthritis. So my advice would be to have a low threshold to start anti-TNFs so that we can stop this patient having further erosive disease. Purushottam sir.
Methotrexate, did he stop methotrexate or continuing now?
No, sir, we are continuing methotrexate along with IV
Methotrexate needs to
bisphosphonates.
continue. Yeah, I agree. Completely agree. But I would have added anti-TNF because pamidronate may not help with because there is with the ESR of 120 and erosive damage of sacroiliac joints and temporomandibular joints, I would be very reluctant to put the patient just on bisphosphonates.
Adalimumab will work in CRMO also.
Yeah. Anti-TNFs are very good in CRMO also. It works for both.
So ideally, this is better. Hit hard.
Yeah.
Okay.
If there is a bit of time, I can go through a few slides on CRMO. If not, we can call it a day.
No. You continue. I think we have time.
Yeah. So CRMO or CNO, as it is often called now, which is chronic non-bacterial osteoarthritis, it's a non-infectious inflammatory bone disease characterized by sterile bone inflammation. It primarily affects children and young adults, and I'll talk about the equivalent in adults as we go along. Now, the incidence is a bit underreported. There is clearly some evidence that the incidence of CRMO has really gone up after COVID, because we used to have 1 or 2 patients every year before COVID. Now we get like 5 to 6 patients, if not sometimes 10 patients every year with CRMO. So there is definitely an increase, and we have recently done a study through the Royal College of Pediatrics, and it shows that an increase in incidence in CRMO in the last 4 or 5 years. The peak incidence is usually 9 to 11 years. It is more common in girls, although in our hospital, it is perhaps 1 to 1. It is in the population we see in UK, it is more common against white Caucasian people, and I can't think about any Asian or African boy who has had CRMO. The question about pathogenesis, is this auto-inflammatory or is this autoimmune? Now, why do we suspect auto-inflammatory? Because there has been number of studies which showed an increase in pro-inflammatory cytokines like IL-1, IL-6, IL-20, etc. But equally, many of these patients have a personal or family history of autoimmune diseases like psoriasis, inflammatory bowel disease, etc. So the question is this autoimmune or auto-inflammatory? But the most recent research has definitely said that this is an inflammatory bone condition. It's an auto-inflammatory condition, not an autoimmune condition, but it can be triggered in patients who have got autoimmune pathology. One of the barriers in diagnosis is there is no current diagnostic or classification criteria that is validated to use in children. So to summarize, the name is very explanatory. It is usually a chronic condition, which means the onset is insidious, and the patients often take 6 to 12 months to make a diagnosis. One of the challenges is the symptoms are waxing and waning, which was typically demonstrated in this boy. He had a waxing and waning story, history of exacerbation of symptoms lasting 1 to 2 weeks. Once he has naproxen, it goes down. Once they stop it, it recurs again. That is quite typical in these patients with CRMO, which is not what we would expect in GIA. Patients with GIA, unless we have given them steroids in some form, either joint injections or IV steroids or oral steroids, the symptoms do not usually remit by itself. And multifocal is very important. Most of the patients on an average have 2 to 3 sites at presentation. However, in up to 40% of patients, it can be unilateral. And the 2 common sites for unilateral disease, one is the medial end of clavicle and the other is mandible. So when most of the unilateral patients have these 2 sites. Otherwise, the commonest sites are lower limbs. And as I said, the classical sites are clavicle, pelvis, spine, and mandible. Another challenge in managing patients with CRMO is they can have asymptomatic sites. And if there is an asymptomatic involvement of spine or vertebra, we need to be very careful because there is a risk of compression fractures, which is why sometimes we have to escalate the patient from NSAID to bisphosphonates um, based on the whole body MRI findings because of the risk of spinal fractures. And obviously the pathology is osteomyelitis and the commonest symptom is bone pain. But always beware that if the the pathology is adjacent to the joint, it almost always gets interpreted as a joint problem rather than a bone problem. So like Purushottam sir mentioned, it's important to find out whether it's actually in the joint or the bone adjacent to the joint. Typically, constitutional features are rare. Very rarely do you get patients who have got fever and high inflammatory markers. The ESR and CRP usually are normal or mildly elevated, and these patients do not classically respond to because if it's a single side disease, often these patients are treated as osteomyelitis because they come to us after 6 to 8 weeks of antibiotics with no response when it's obvious that this is not an infection. The commonest sites are you get metaphyseal involvement. It's usually a symmetrical disease. Again, there is something called when you have the classical sites, there is a negative correlation with the multifocality. So if they have, for example, clavicle disease or mandibular disease, there is a high chance that they may not have secondary sites, in other words. 1/3 of the patients can have vertebral involvement, which is very important. In our own patients, up to 1/4 of all patients had unifocal presentation. But when we did the whole body MRI, nearly 90% of them had more silent sites present, which is why whole body MRI is now kind of considered as a gold standard in diagnosis of CRMO because it can pick up other silent features, and it can also mean that patient doesn't have to go through invasive procedures like bone biopsy, which we used to use quite often in the past. Another challenge we have is there are no diagnostic criteria. However, Bristol diagnostic criteria as proposed by a team in Bristol has been helpful for some centers, but it's not internationally validated and we don't use it. So basically it means that you need to have typical clinical features and present of typical radiological findings. So what does that mean? You need to have involvement of more than one joint without significantly raised CRP. If it's a unifocal disease and it's other than clavicle, or if the patient has got high inflammatory markers, it is better to do a bone biopsy. So the indication of bone biopsy is by and large unifocal disease in a non-typical CRMO site. So it is essentially a diagnosis of exclusion. Laboratory investigation, again, most of these investigations are carried out more to exclude other conditions than to ring in the diagnosis of CRMO. The new full blood count is characteristically normal. If it's abnormal, we need to consider this being a hematological malignancy. Usually inflammatory markers are normal or mildly elevated. If there is a setting for scurvy, there is some merit in doing vitamin C, but vitamin C is an incredibly difficult blood investigation to do because it has to be done in certain containers, sun protected and stuff to get an accurate result. The best thing to do if you are suspecting scurvy is to give them treatment dose of vitamin C. That is the best diagnostic investigation. If they get better, that is scurvy, nothing else. Again, LDH, high LDH should make us suspicious of malignancies. Autoantibody screen are not helpful from a CRMO point of view, but they may suggest alternate diagnosis. Again, there is a high association of HLA-B27 in CRMO patients. So it's reasonable to do HLA-B27 in these patients. If we get unifocal disease, we always go for microbiology to make sure this is not an osteomyelitis. There are some chemokines being touted as future diagnostic, but none validated at this point in time. So like I mentioned earlier, the differential diagnosis, if it's a unilateral disease, we always need to consider infection. In fact, many of our patients who have got disease in talus, tibia, etc., come to us after a few weeks of antibiotics with no improvement. Neoplasia is another differential diagnosis. Again, not relevant in this patient because the longevity of the symptoms, but if it's a new patient, we would need to consider primary orthopedic neoplasms or bone neoplasms like Ewing's and osteosarcoma, secondary like lymphoma and leukemia. Lymphoma is especially common to present with bone symptoms. We don't really sometimes underestimate the importance of musculoskeletal presentation in leukemia. After 25%, 1/4 of all leukemia present with bone or musculoskeletal symptoms. LCH, Langerhans cell histiocytosis can also. Rarely, benign bone tumors like osteoda osteoma can present with symptoms similar to CRMO. So if I get patient with unilateral knee symptoms, I always try and do an X-ray or a CT scan to look for an osteoda osteoma if it's a long-standing pain and this patient has got significant disability because of that. Other differential diagnosis, JIA, again, the most common subtype that we confuse with CRMO is enthesitis-related arthritis, which is the crux of discussion today. It is a nutritional condition like scurvy and fibrous dysplasia, which we all know as a part of McCune-Albright syndrome, and it could be monostotic and polyostotic, can be a differential diagnosis for CRMO. And rarely, malunited fractures, especially clavicular fractures, have come to us because I'm saying that this is CRMO, but that's nothing more than a malunited fracture. What about imaging? So there is general consensus that gold standard for diagnosing CRMO is MRI scan because it's incredibly sensitive in detecting bone marrow edema. It gives you a clear extent of bone inflammation. And it also gives us an assessment of structures around the bones like soft tissue inflammation. And the big advantage is that there is no radiation. CT scan offers a radiation risk. It is very good if you want to get more information about the bone in detail. For example, if you are looking for a Brody's abscess or if you are looking for a sequestrum, then CT scan is more helpful than MRI scan. But if you are worried about CRMO, the first diagnosis would be to look for bone marrow edema on MRI. Now, what next? So as I said, whole body MRI has now become a gold standard for diagnosis of CRMO because it's more specific for bone marrow edema. It also detects joint and soft tissue involvement. It is quite sensitive in picking up more lesions, especially vertebral lesions, which is what we are worried about. There is no radiation involved. And this is very important. If you are able to pick up asymptomatic lesions in a clinically unifocal disease, we can avoid invasive procedures like bone biopsy in these patients. And sometimes we have had a surprise. When you have done a whole body MRI, then they have picked up like a splenomegaly or lymph nodes in the abdomen. The patient has turned out to be a lymphoma rather than CRMO. Sometimes it gives you a bonus information. Whereas bone scan is less specific than whole body MRI. It involves high radiation and the interference from the epiphyseal growth plates in children is a big problem, whereas there is no such interference in patients with whole body MRI. But obviously the advantage is it's a shorter procedure and children often don't need sedation or anesthesia to do that. To do this in a child who is uncooperative, who has got neurodiversity or neurodisability is a bit of a problem. So when do we do biopsy? We have only done biopsy in 3 out of the 18 patients who we have under treatment at the moment. And they all had unifocal atypical sites, for example, femur and tibia and stuff like that. We are definitely looking, what do we get on the biopsy? We just get inflammatory cell infiltration, fibrosis, and sclerosis. In our own cohort, about 50% had biopsy and 50% of them had mandibular biopsy. So these patients present to mandibular swelling, they come onto the oncology pathway. So the maxillofacial surgeons automatically do a biopsy to rule out a leukemia, lymphoma, or other infiltrative conditions. So the biopsy was not definitely asked by the rheumatology team. They would have had the the biopsy at the time of diagnosis with suspected oncological neoplasia. So what are the associations of CRMO? We briefly discussed that. Palmoplantar pustulosis is one. One of the commonest conditions is psoriasis. Now, it's interesting to know that patients with psoriasis can develop CRMO. But when we treat CRMO patients with anti-TNF medication, that can cause anti-TNF induced psoriasis as a complication. So we've had 2 or 3 patients with CRMO who, when we gave anti-TNF, they developed paradoxical psoriasis, and we had to stop anti-TNF because of that. So we need to take that into mind when we consider the patients who have got no psoriasis or no skin manifestation. It's usually not a problem. Then the next commonest is arthritis, especially HLA-B27 associated enthesitis-related arthritis and sacroiliitis. Acne is an association, and then inflammatory bowel disease is an association. We have had 1 or 2 patients in my 20 years in rheumatology who have had a large vessel vasculitis, Takayasu's arthritis, in a patient who earlier had CRMO. Pyoderma gangrenosum can be seen in some of these patients, and very rarely it can be associated with ANCA-associated vasculitis. So this is the split in our patients, but then this is a spectrum. So a lot of CNO, CRMO patients have a common association with acne, inflammatory bowel disease, ankylosing spondylitis, and psoriasis. So what are the variants of CRMO? So Sappho syndrome is probably the commonest. So the main difference is the age group. Sappho syndrome is usually seen in young adults but can affect older children. It is an acronym which stands for synovitis, acne, pustulosis, hyperostosis, and osteitis. Like CRMO, it is commoner in girls. Again, there is 1/3 association with HLA-B27. But one typical difference between CRMO and Sappho is Sappho has got a very high risk of involvement of anterior chest wall, especially sternum. We can get clavicular disease in CRMO, but involvement of sternum is very rare. If you get patients with sternal involvement, obviously we need to think about neoplasia as a secondary or something. But if it's not, then Sappho syndrome is quite high up in terms of diagnosis. And there is also risk of sternoclavicular joint involvement. Otherwise, rest of the joints involved are very similar to CRMO, like pelvis, vertebrae, mandible, etc. Although clavicular involvement itself is not that common. A common association is again palmoplantar pustulosis. If a patient presents with bony lesions suggesting of CRMO very early on in the life, before the first year or in neonatal period or infancy, what are the things we should consider? Majeed syndrome is an inherited condition where you can get congenital dyserythropoietic anemia, neutrophilic dermatosis, and sterile osteomyelitis. It's sometimes described as an infantile version of CRMO, but this is definitely, this was detected in a group of Iranian patients described by the person who gave the name to the syndrome. The age of onset is usually before 2 years of age, and the symptoms are quite typical with high inflammatory. The symptoms are quite typically inflammatory with recurrent fever and bone pain, anemia, hepatosplenomegaly, and very high ESR and CRP. Regarding the bone involvement, we don't get the classical CRMO sites like clavicle, mandible, and pelvis. It's usually predominantly in the lower extremities, especially tibia and femur. Another condition is DIRA, which again you can see. DIRA is the deficiency of IL-1 receptor antagonist, which means that these patients have an uncontrolled effect of IL-1 leading to sterile multifocal osteomyelitis, periosteitis, and pustulosis. Again, these patients respond remarkably well to anti-IL-1 treatment, which, as I sit here, I painfully understand is not available for treatment in India at the moment. I'll just am I all right in terms of time, or I can stop now?
How many slides more, Kishore?
2 or 3, I think. 3 or 4.
Go ahead.
Yeah. So, and then treatment goals, as one would imagine, the most important thing is symptom relief, bone pain, and we would want to reduce inflammation. So look at reduce focal inflammatory signs, inflammation markers if applicable, and reduction in the radiological signs of inflammation, especially bone marrow edema. Equally important is, like Purushothaman sir, is to maintain and regain functional capacity, especially reported by fatigue and patients' activity levels is very important. So when I have a patient with CRMO come to me who is not wants to play football, can't play football, first thing I said is the whole idea is that we treat you so that you can go back to playing your football, because they can be so passionate about it, and that can even affect their emotional and mental state if they can't do what they want to do. And obviously to prevent the progression of structural damage. Management, again, currently there are no guidelines. The consensus is that the first line treatment is NSAIDs. So up to about half of the patients do respond to NSAID, but the problem is very high relapse rate. If we stop NSAID, they often flare. One indication to escalate the treatment from NSAIDs when they have active spinal lesions, which is why whole body MRI scan is important. If there is asymptomatic vertebral involvement, to prevent the risk of compression fractures, we need to escalate. There are three options. One is conventional synthetic DMARDs like methotrexate and sulfasalazine. The other option is use bisphosphonates like pamidronate or zoledronate, and biologics, mainly anti-TNFs. Methotrexate is more commonly used than sulfasalazine, but the response rates are fairly low, according to international studies, anywhere between 20 to 40%. Whereas bisphosphonates have been very successful in the treatment of CRMO, and depending on which study we follow, it varies from 70 to 90%. It works obviously by inhibiting bone resorption. It also restores an imbalance between pro and inflammatory cytokine. The two ones which are commonly used are pamidronate and zoledronate. Now, the good thing about zoledronate is we only need to give one dose, and it usually works for about 6 months. Whereas pamidronate is given as 3 doses, it only works for 2 to 3 months. So for that reason, we have started to preferentially use zoledronate. At the moment, I'm involved in a collaboration with mainland Europe to look for efficacy and side effects of zoledronate versus pamidronate. Hopefully, it will be published before the end of this year. One very rare side effect is the osteonecrosis of jaw. We call it bronch. But it's very reassuring that it has almost not been reported in pediatric population at all. But following zoledronate, we strictly advise our patients not to have any elective dental work like extraction or orthodontic work done for the next 3 to 6 months. Bisphosphonates versus anti-TNF. Sadly, there are no head-to-head trials, but there is some theory to say that for vertebral lesions, bisphosphonates may be better. But however, there are patients who are poor responders, especially females with higher number of lesions and higher CRP and ESR are less likely to respond to bisphosphonates. So given that in this patient that he has got traced inflammatory markers, sacroiliitis and evidence of inflammation in his wrist, and the fact that he has already got erosive changes in SI joint and his TMJ, I would want him to be, I would really recommend starting him on anti-TNF to prevent further damage. We always use our multidisciplinary team while managing these patients. They all have some role. Our physiotherapists are very important to make sure that they get back to the activities. Our nurse specialists help with counseling these patients about the side effects of medication. And we have often got other members when they are struggling with symptoms like chronic pain and emotional things. We have a psychologist to help. We often have to work closely with other specialties as well. For example, a lot of patients with mandibular lesions come to us through maxillofacial surgeons. Orthopedic surgeons often required for biopsy. Radiology is very important, and sometimes our dermatology colleagues are required to manage some of the dermatological associations. Complications, as I've discussed, fractures can happen, especially vertebral fractures, which is what we are trying to prevent. Like Purushottam asked earlier, there is a chance of bony deformities, which is usually because of hyperostosis. And the shorter you take to diagnose and treat them, lesser the likelihood of hyperostosis. And some patients often go on to a chronic pain situation, which we need to manage with psychological and other maneuvers, these patients. What does the future hold? hopefully we'll have a better understanding of the pathogenesis. Hopefully we'll have a classification criteria in the future and some useful biomarkers that maybe tell us which patient is active, which patient is going to flare. It'll be nice to have some clinical trial between bisphosphonates and biologics, and we may have new treatments coming up like anti-IL-1 agents and anti-rankle agents in the future. And with that, I come to the end of my presentation, and thank you very much for having me. I'm happy to take questions.
Can I ask a question,
Yes, please, madam.
Kishore?
Yeah.
What about PET scans in monitoring the?
So actually, UK is a much poorer country when it comes to PET scans than India, because there are very stringent guidelines as to what we can use PET scans for. So PET scans are not usually considered in patients unless we are suspecting a hematological malignancy like lymphoma. They are better reserved for patients. There are two indications for which we roughly refer to patients to PET scan. Is one is lymphoma and other is large vessel vasculitis. So a PET scan may be helpful because it may pick up an active aortitis in a patient with CRMO, which tells us that this patient may have an associated large vessel vasculitis. But for monitoring bone lesions, PET scans are much inferior to MRI scans because what we are looking for is the extent of bone marrow edema and the extent of involvement of the bones. So we usually prefer MRI scans over PET scans for these conditions.
Okay, thank you.
Mohandas is the Mohandas, sir?
Hello. Sir.
Mohandas, Geetha ille. Geetha comments.
Geetha poi.
Oh, no. Oh, I would like to.
Purshu. Kishore. That was excellent.
Thank you.
Eh? Kishore ഒന്ന് കണ്ടോട്ടെ.
Kishore, excellent ആയിരുന്നു ട്ടോ പറയാം.
Thank you, madam. Thank you, everyone.
Nice to see you.
Thank you.
Nice to see you.
Thank you.
ആകെ മുഖം മാത്രമേ കാണുന്നുള്ളൂ കേട്ടോ ശരിക്കും. Purshu, Mohandas, and that girl presented very well. Excellent. The way she
Thank you very much, sir. Thank
and
you.
that was filled by Purshu. I think we should mention about the spleen because we have seen children receiving methotrexate coming for thrombocytopenia and getting into problems. That was rightly pointed out by Purshu. Excellent. That was a very good review.
Thank you, sir.
Well presented.
Thank you, sir.
Excellent discussion, Kishore.
Yes.
Sir, it's always a pleasure to see you all and discuss with you all. And it's always
when we requested Kishore to whether he can come for this discussion, he without any hesitation he agreed. Thank you, Kishore, for accepting the invitation.
It's always a pleasure. Always a pleasure.
You did the right thing.
Anyway. I was a little bit hesitant whether it will be a difficult time for him, whether he may be having his consultations at that time.
Thursday mornings ഉച്ചയ്ക്കില്ല അപ്പൊ അത് ഞാൻ പറഞ്ഞു ഞാൻ ഡയറി നോക്കി ഫ്രീ ആണെന്ന് കണ്ടാൽ ഞാൻ ഒരിക്കലും I never hesitate. I never have a problem. Thank you.
That's like wind up.
So we can wind up. Thank you, Kishore, for that excellent.
Kishore, good night.
Good night. Thank you very much. Thank you. Nice to see you all.
Good night. Thank you, sir.
Kishore.
Bye. Thank you.
Rajesh ഉണ്ട് അവിടെ.
Rajesh.
Yes, sir.
Purshu.
Thank you.
Parvati. Okay.
Thank you, sir. Good night.